Here we are at EULAR 2025, day 2. I'm Dr. Valentina Puccino, Assistant Professor and Consultant Immunorheumatologist at University of Pisa, Italy, and I'm delighted to be joined here by Professor Peter Nigrovic, Pediatric Professor from Harvard University. Thank you for joining me today. First of all, congratulations for your work in the field of Still's disease, and I have a few questions for you.
Thank you for taking the time.
So first question I'm very curious about is can you please explain about similarities between child and adult onset of Still's disease?
Yeah, it's a very interesting question, I think. The whole field of division between pediatrics and adults in rheumatology came out of a funny historical divide, a paper in the 1950s, which used an arbitrary cutoff of 16 to define who's a child and who's an adult. And there was never any biology behind that, and there still isn't. So it turns out that most of our pediatric diseases are completely contiguous or continuous with the patient, with the adult diseases. I'm trained in both adult and pediatric rheumatology, and so I take care of both, and they look very similar to me. In particular, for Still's disease, I think that the biology looks very similar. The biomarkers look very similar. The clinical responses are very similar. So I think they're identical. And fortunately, the recent guidelines from PRESS and EULAR from Bruno Fortrell and Fabrizio De Benedetti have now formalized that and recommend that these two diseases, systemic JA and adult onset Still's disease, should be called one name, which is Still's disease.
Okay. Thank you very much for this clear explanation. And let's move on to the second question. So what I wanted to ask is whether have new mechanisms been identified of the disease, and there are different phenotypes of disease as well?
So I think even though the continuum is the same across adults and children, there are different phenotypes within that continuum. And how that arises still is not fully understood. So there's been efforts to use, for example, single-cell RNA sequencing or other techniques to identify biological subgroups in this population. And I think that works interesting, but not yet definitive. There are the one interesting subphenotype that's emerged over the last 10 years has been a lung disease in this population, which affects specifically children. So lung disease is a phenotype that appears often, can be present at diagnosis, but appears sometimes a year or more than a year into presentation. Sometimes in the context of what look like allergic features, such as eosinophilia or reactions to drugs. And it can be progressive and lead to decrease in lung function, oxygen dependence, even death. So it's a very severe and serious consequence. And I think there's a lot of concern in the field about how it arises. Does it arise because of drugs that we're using, for example, because we use a lot of biologics now, IL-1 blockers and IL-6 blockers. So could they be causal? Or is it some other issue that's happening, some other environmental exposure that's happening now more? Or, for example, something that we're not doing. For example, we're not using much steroids at the onset of disease anymore. We're not using very many DMARDs, such as methotrexate, early on in the disease like we used to. So it's a very interesting subphenotype that I think bears a lot of ongoing research.
Very good. And let's move on to the next question. The last question is about how do you feel? Do you feel optimistic about new targets that can predict the progression of disease, and of course also new treatments on the horizon that can make the patients feel better, especially for complications like the macrophage activation syndrome?
Yes, I feel very optimistic about the disease. I think we have done amazingly with biologics. We use IL-1 blockade or sometimes IL-6 blockade early on, and I think those are extremely promising therapies. They don't fix everyone, so there's still 20% or more of patients who have refractory systemic JA or Still's disease, and they need other options. So IL-18 blockade is on the horizon, and I think that's very interesting. Combination therapy, I think, is going to be very interesting between drugs that we know, and then between biologics and between drugs that we know. And then I think there's a target that we defined in the laboratory, mTOR, which, as you know, is a metabolic regulator, and that we find both in humans and in animal models of arthritis, of stills like arthritis, that you have a very striking mTOR signal. And there are a few interesting case reports now of patients treated with mTOR blockade that seem to respond well. Those are just two isolated case reports at this time, but I think based on the biology of the disease and I think that's a potentially promising target to investigate.
Oh, that's very exciting, and I can't wait to see the result of this study. Thank you very much for joining me today, and thank you everyone for listening, and enjoy the rest of the conference.